Across clinical trials, PRP has been studied using different preparation techniques, different injection schedules, and different patient populations. Some studies evaluate a single injection, while others involve a series of 2 or 3 injections spaced several weeks apart. Are you ready to get back to what you love after knee replacement? The Total Knee Success Podcast is your trusted guide with practical tips, evidence-based strategies, and no fluff. It's not personal medical advice, just solid education to help you manage pain, regain mobility, and get back to living the life you love. Let's dive in. Welcome back to the Total Knee Success Podcast. I'm Michelle. This is part 3 of a 4-part series, Before Total Knee Replacement, What Injections Really Do. In the last episode, we talked about gel injections, also known as hyaluronic acid injections, and how they interact with the joint fluid environment inside the knee. Today we're turning to another injection that often comes up when people are exploring ways to delay knee replacement, platelet-rich plasma, commonly known as PRP. By the end of this episode, you'll understand what platelet-rich plasma actually is, what the experience of receiving a PRP injection typically looks like before and after the procedure, what the current research shows about symptom relief for knee arthritis, and how this treatment fits into the bigger picture of managing knee symptoms over time. When patients first hear about PRP, it's often described using the language of regenerative medicine. Clinics may describe it as a treatment that uses your body's own healing system to repair damaged tissue. Because the injection comes from your own blood, it's frequently framed as a natural approach to joint health. That description is appealing, but the biological and clinical reality is more nuanced. PRP begins with a standard blood draw. A small amount of blood is taken from your arm, similar to what you would experience during routine laboratory testing. That blood sample is then placed into a centrifuge. A centrifuge spins the sample at high speed, separating the components of blood based on density. Whole blood contains several key components: red blood cells, white blood cells, plasma, and platelets. Platelets are small anucleate cell fragments derived from megakaryocytes in the bone marrow. They are best known for their role in blood clotting or hemostasis, where they help form a platelet plug at sites of vascular injury. In addition to this clotting function, platelets contain intracellular storage structures called alpha granules that hold numerous signaling proteins known as growth factors. These growth factors, including platelet-derived growth factor, transforming growth factor beta, vascular endothelial growth factor, and insulin-like growth factor, play important roles in cell signaling related to tissue repair, modulation of inflammation, and regulation of local healing responses within musculoskeletal tissues. The goal of PRP preparation is to concentrate platelets into a smaller volume of plasma so that the final injection contains a higher platelet concentration than normal circulating blood. Once this platelet-rich layer is isolated, it is injected directly into the knee joint. The theory behind PRP is that these concentrated growth factors may influence inflammation, cellular signaling, and tissue repair pathways within the joint environment. Laboratory studies have shown that platelets release growth factors such as platelet-derived growth factor and transforming growth factor beta, which can influence cell behavior and inflammatory responses in cartilage and synovial tissue. For example, Filardo and colleagues reported that intra-articular PRP injections in patients with degenerative cartilage lesions and early knee osteoarthritis were associated with improvements in pain and function scores over follow-up periods of up to 12 months, suggesting that these biologic signaling pathways may contribute to the symptom improvements reported in some clinical studies. One of the most important things to understand about PRP is that there is no single universal preparation method. Different clinics use different centrifuge systems, spin speeds, and processing protocols. Some preparations contain higher concentrations of white blood cells, while others attempt to remove them. Platelet concentration itself can vary significantly depending on how the sample is processed. This means that 2 patients receiving PRP injections at different clinics may not actually be receiving the same biological product. In other words, PRP is not a single standardized treatment, and that variability makes research interpretation challenging. Across clinical trials, PRP has been studied using different preparation techniques, different injection schedules, and different patient populations. Some studies evaluate a single injection, while others involve a series of 2 or 3 injections spaced several weeks apart. Despite this variability, several systematic reviews and randomized controlled trials have found that PRP may provide modest improvements in pain and function for some individuals with knee osteoarthritis, particularly those with earlier stage disease. Meta-analyses comparing PRP with placebo or hyaluronic acid injections have reported small to moderate improvements in pain scores lasting several months in some patients. Large treatment comparisons summarized by Bannerou and colleagues show that many injection therapies for knee osteoarthritis produce modest average improvements when evaluated across large patient populations. Day and colleagues, in a meta-analysis of randomized controlled trials, found that patients receiving PRP often experienced greater reductions in pain and improved functional scores compared with placebo or hyaluronic acid injections in several studies. Similarly, a systematic review by Belk and colleagues comparing PRP with hyaluronic acid injections reported superior improvements in pain and function for some patients receiving PRP. In a randomized controlled trial led by Cole and colleagues, patients receiving PRP also reported greater improvements in pain scores than those receiving hyaluronic acid injections over follow-up periods approaching 1 year. Reviews examining the timing of improvement suggest that symptom relief often develops gradually and may peak between 3 and 6 months after treatment, with some patients maintaining a benefit for up to 12 months. More recent systematic reviews have reached similar conclusions. For example, Zhao and colleagues reviewed randomized controlled trials of PRP for knee osteoarthritis reported that PRP injections were associated with greater improvements in pain and function scores than several comparison treatments, although the size of improvement varied across studies and patient groups. Some patients report noticeable improvement while others report little change. Occasionally you may hear stories like this. Someone receives PRP injections in both knees and feels meaningful improvement in one knee while noticing very little change in the other. I once knew someone who described exactly that experience. Even though the treatment was the same, the biological environment inside each joint can be different. Differences in disease severity, joint mechanics, inflammation levels, and cartilage damage may influence how each knee responds. Current clinical studies have not shown reliable cartilage regeneration in advanced osteoarthritis. Studies evaluating structural changes within the joint have not demonstrated reliable cartilage restoration in patients with severe arthritis. Most observed benefits relate to pain reduction and functional improvement rather than reversal of structural degeneration. And this distinction is especially important for people already considering knee replacement. Total knee replacement is usually considered when osteoarthritis leads to persistent pain and functional limitations that no longer respond well to non-surgical treatments. At that stage, the joint surfaces have undergone generally years of degeneration. Cartilage loss, bone remodeling, and inflammation and mechanical alignment changes all contribute to symptoms. Injecting concentrated platelets into that environment does not rebuild the joint surfaces. Instead, what PRP may do for some patients is influence inflammatory signaling and pain pathways within the joint for a period of time. For individuals with earlier stage arthritis, those changes may translate into noticeable symptom relief for a period of time. Research summarized by Filardo and colleagues suggests that younger individuals and those with milder radiographic osteoarthritis often report greater improvement with PRP than patients with advanced joint degeneration, where cartilage loss and structural changes inside the joint are more severe. Clinicians often describe osteoarthritis severity using the Kellgren-Lawrence grading system, which ranges from grade 1, showing minimal joint changes, to grade 4, where the joint space may be severely narrowed or absent. PRP studies tend to show stronger responses in patients closer to the grade 1 than to the grade 4. Now let's talk about the practical experience of PRP from a patient's perspective. Before the injection, most clinicians recommend avoiding anti-inflammatory medications for a short period of time. This typically includes medications such as ibuprofen, naproxen, or other nonsteroidal anti-inflammatory drugs. The reason is that PRP relies on inflammatory signaling as part of its biological effect, and anti-inflammatory medications may theoretically blunt that response. Protocols vary, but many clinics recommend avoiding nonsteroidal anti-inflammatory medications for several days before and after the injection. On the day of the procedure, the process usually involves 3 steps: the blood draw, the centrifuge preparation, and the injection itself. The entire visit typically takes between 30 minutes to 1 hour. In current musculoskeletal practice, ultrasound guidance is increasingly standard for PRP injections because it allows the clinician to see needle placement in real time and improve accuracy inside the joint. Patients may feel temporary pressure or discomfort during the injection, although experiences can vary. After the injection, it's common to experience a temporary increase in soreness or joint irritation for several days. This reaction is sometimes described as post-injection inflammatory response. Ice, relative rest, and acetaminophen are often recommended during this period. Acetaminophen is not an anti-inflammatory. Exercise recommendations after PRP typically progress in stages. During the first several days, most protocols recommend relative rest and avoidance of high-impact activity. Light walking and gentle range of motion movements are usually allowed. The goal during this early phase is to allow the biological response to occur without excessive mechanical stress. During the following 1 to 2 weeks, patients often begin gradually reintroducing strengthening exercise, quadriceps activation exercises, stationary cycling, and controlled functional movements may be introduced depending on symptoms. By 3 to 4 weeks after injection, many rehab programs transition toward progressive strengthening and return to higher level activities as tolerated. Strength training, gait training, and functional movement exercises remain central during this phase. This progression reflects an important principle we discussed in earlier episodes. An injection that reduces pain creates an opportunity. If discomfort decreases, that window can be used to improve strength, movement quality, and joint mechanics. Without that rehab component, symptom relief alone may not lead to meaningful long-term functional change. One of the biggest mistakes people make before knee replacement surgery is assuming that they are ready without really knowing where they stand. The truth is the work you do before surgery can make a big difference in how recovery goes. And that's why we created the knee replacement game plan. It's a guide designed to help you prepare step by step before surgery. It's educational in nature. And inside the book, you'll also find the Total Knee Success Readiness Score, which helps you evaluate important factors that influence recovery. Things like strength, mobility, daily function, lifestyle habits, and the support you have around you. The goal is to help you understand where you are now and where you may want to focus before surgery, so you could set yourself up for a smoother recovery. If you'd like to learn more or get a copy of the knee replacement game plan, just check the show notes or visit totalkneesuccess.com. Now, before we move on, there is another practical question that often comes up when people are considering PRP injection, and that's cost. Unlike cortisone injections or some hyaluronic acid injections, PRP treatments are frequently not covered by insurance. Costs often range from several hundred to a few $1,000s per treatment, depending on the clinic and the number of injections recommended. Because these treatments are often paid out of pocket, patients understandably want to know whether the improvement they might experience is likely to justify the cost. The most accurate answer from current research is that PRP may help some patients experience temporary symptom improvement, particularly in the earlier stage osteoarthritis. But responses are variable, and structural joint changes are not reversed. Understanding this helps set realistic expectations about what PRP can and cannot do. PRP is best viewed, I think, as a symptom-modifying intervention rather than a structural repair strategy. In the context of preparing for knee replacement, some individuals try PRP while they're still deciding about surgery. Others pursue it because they hope to delay surgery for a specific period of time. In both situations, the key question becomes whether temporary symptom relief meaningfully changes the larger plan for joint health and function. I suggest you discuss it with your orthopedist and then just make an informed decision for yourself. In our next episode, we will continue this series by examining stem cell injections. These treatments are often marketed as the next step in regenerative medicine for knee arthritis. We will explore what most stem cell injections actually contain, how they're regulated, and what current evidence shows about their effectiveness. Understanding these distinctions allows you to evaluate treatment claims with clearer expectations. Thanks for joining me. I'm Michelle, and this has been the Total Knee Success Podcast. This podcast is for educational purposes only. Discover more at totalkneesuccess.com, and be sure to subscribe and share, because every step forward takes you closer to living the life you love.